Okay, so basically the topic was urinary bladder, so I thought you will get some ideas about the renal tumor. So renal tumor, now when we say a word that is called as tumor, tumor means it is basically a outgrowth which is not normal. It is something which is an excessive growth in a tissue. Now when it's happening in the kidney, it's called as a kidney tumor. So before we basically go into the kidney tumor, we should know what is a kidney, where it is lying, what are its basic functions. So basically kidneys are retroperitoneal organs. They are basically lying on both sides of the vertebral column and resting onto the psoas muscle. It is something which is basically around a bilateral, or we can say a paired organ, approximately around 11 centimeters in its length. Right kidney, as we can see, is somewhat a bit lower than the left kidney, and that's because of the presence of liver which is pushing it down. This kidney is actually a very vital organ in our body. It is almost receiving around 20% of the cardiac output, and it has variety of functions to do. Now these functions basically include the maintenance. The main important thing is the filtration of all the waste products, excretion of them outside the body, and reabsorption of all the required material. Apart from that, they are playing a very important role in the homeostasis as well, and that is because of secretion of certain very vital hormones, which includes the renin, angiotensin, aldosterone. So basically the renin secreted from the kidney helps in maintenance of the osmolality. It also helps in maintenance of the blood pressure of the body as well. So basically there are various functions that the kidneys perform. Now as we just basically see, this is the bilateral paired organ lying on the sides and ultimately resting onto the psoas muscles. It's a retroperitoneal organ moving with respiration. Now when we see the cut section of the kidney, this is important because a cut section is dividing the kidney into two parts. One is the cortical part, which is basically the whitest structure, and the other brownish one is actually the medulla. Now this medulla and the cortex both can have the growth of the tumor. Most common growth that is basically seen in kidney tumors is from the cortex. So basically when it is coming from the cortical tumors, it is actually the adenocarcinoma, and when it is coming from the medulla or coming from the pelvic ileal system, it is actually the transitional cell carcinoma. Both are different. Okay, so we'll today discuss about not the transitional cell but with the adenocarcinoma. As we can see, there is basically this is very important to know. Why? Because we can understand later on how the stage goes about. So basically as we can see, the kidneys are here. This is basically surrounded by a capsule which is known as a renal capsule. This is the renal capsule which is basically encircling the kidney, and then there is basically a perinephric fat which just surrounds the kidney. We can see a green line that is separating these two yellow fats. One is the perinephric fat, the other is the paranephric fat. Anything which is outside the Gerota's fascia is the paranephric fat. If a tumor is basically entering in this area, it is already an advanced condition. Simply a tumor that is entering in this area has a lower stage, and a tumor confined to the kidney is having even lesser stage. That is why this particular diagram is an important one. As I already said, that it is a very vital organ having 20% of the cardiac output. The functions are very important: blood pressure regulation, osmolality because of the renin that's secreted, excretion because of the all filtration system, that is the glomeruli, the tubules. They basically have this counter current mechanism by which they are having the absorption, reabsorption that's taking place, and ultimately all the vital ions, all the vital elements which are required in our body are reabsorbed, rest are excreted. So renal tumors, coming back to the main topic, it is a very important tumor that is actually seen more onto the Northern America or the Scandinavia areas, lesser in India, but still it is on a growing trend. So it is basically, that is the reason very important. Now tumors are not always dangerous. When we say about tumor, it is actually something which can be a benign tumor, which can be a malignant one. Now what is benign? Benign is something which is non-cancerous, which is something that is not growing too aggressively. The one that is growing very aggressively, the one that is dangerous to the body, the one that's having a poor prognosis is actually the malignant one. Okay, so benign ones are basically having three most important varieties: the oncocytoma, We are not going in details of the benign ones, but we just need to remember the gist. Oncocytoma is something which is almost similar to that of a renal cell carcinoma in terms of its basic pathological picture. The only thing that actually separates them is a central scar. Apart from that, yes, the definite symptoms are there. Papillary adenoma, again a benign tumor, and angiomyolipoma is one of the most common of the benign tumors, having three components. One is the blood vessel, the other is the smooth muscle, the other is the fat. So it is made up of three different elements, angiomyolipoma, as the name suggests. We will be discussing next about the cancerous ones. The most common of all is the renal cell cancer. Now, renal cell cancer is also known as hypernephroma. It is something which is also known as the Gravitt's tumor. This particular cancer is actually going to account the maximum amount of the kidney tumors. So basically, benign tumors are not so common in kidneys. Rather, it is the malignant ones which are more common. So it's accounting for about 80 to 85% of the kidney tumors as well. So what is the epidemiology like? As we all know that most of the cancers are affecting the elderly. This is also one of the cancers which is affecting the elderly group. Males are much more affected than the females, and it is the Northern America side which is much more affected, but India is on a growing trend. What we need to understand is that earlier it was seen that it was coming in a local stage, but nowadays it is coming more in a metastatic stage as well. Although earlier diagnosis can improve the prognosis, because if we make an early diagnosis at an earlier stage, the prognosis definitely gets well. This word is important. Most of the tumors are sporadic in nature. What is the sporadic? It means it is individual. It is not associated with any other thing, and normally that comes out unilateral. But when it is associated with any other genetic syndrome, it is something which can be bilateral, which can be multiple. So we need to know two things. One is a genetic associated RCC, the other is a non-genetic one or a sporadic one. Sporadic ones are normally single tumors, single side. These ones are bilateral, or it can be multiple as well. What is the most important thing? Stage of the disease. So if we are diagnosing it at an advanced stage, this is going to have a very poor prognosis. But if we are going to have it at an earlier stage, we can have a longer survival for that same patient. The most important thing that comes across is that the most common type is adenocarcinoma, but because of the variety of histologies that is seen in a renal cell cancers, they have different prognosis for each variety. The most common variety is the clear cell cancer. Clear cell cancer is the most common variety, while the least common of all is the oncocytic ones. Although which has the best prognosis out of all? The best prognosis is seen in the chromophobe type, this one, and which is having the worst of the prognosis, the sarcomatoid type. These are both MCQs, the best and the worst, chromophobe as well as it is the sarcomatoid. So what are the risk factors? Looking at this diagram, it will not be so interesting. Looking at this will be a better option. So what is actually the most common risk factors? Three triad: presence of hypertension, presence of obesity, as well as presence of tobacco smoking. Chewing or smoking. Now these are the three most important things. If they are present together, a patient is automatically at a higher risk. Apart from that, there are certain patients who are having CKD. These are patients who are on dialysis. Now these dialysis patients, they basically tend to acquire acquired renal cystic disease. There are cysts which are created in the kidney, that is on a longer run, and these cysts develop cancer even on longer run. So a patient who is on dialysis for more than 10 years are at a high risk of developing a renal cell cancer with respect to the normal population. So that is the reason presence of end-stage renal disease or presence of CKD is there, because these two things leads to acquired cystic disease post-dialysis and ultimately causing these things. There are certain other things like environmental as well as the occupational. So those who are basically working in the leather industries, those who are working in paint industries, those who are basically working in petroleum industries, and those who are having exposed to the asbestos, all these are also going to be risk factors. So we have till now understood that there are two different types of renal tumors. One is a benign, the other is malignant. Malignant has variety of histologies. Each histology has its own prognosis. Chromophobe, the best variety; sarcomatoid, the least or the worst prognosis. And apart from that, there are risk factors which have been illustrated here. So RCC, as I just said, is not a single disease. We have discussed that there are variety of histologies in this. Chromophobe is the one that is basically having the best prognosis. Now, I just said that there are certain tumors which are sporadic, there are certain tumors which are having genetic syndromes associated with this. This is a very important chart for MCQ purpose. For basically your level, you just need to remember names. So, I am not going into details of each of them, but each and every word in this particular chart is something which comes out as an MCQ. So, basically presence of a von Hippel-Lindau disease. Now, this is the most common syndrome because this is the one that is associated with the most common variety of the tumor, that is the clear cell carcinoma. VHL gene present at the 3p25, again an important MCQ, will be the most common question that is asked in the clinics as well. So, they will be asking you that von Hippel-Lindau disease, can you tell me what is the chromosome that is basically affected? It's the 3p25. Apart from that, there are hereditary papillary renal type 1 and hereditary leiomyomatosis, just remember the name. And one very important one is a Bird-Hog-Duke syndrome. Now, this Bird-Hog-Duke syndrome is a basic variety which is associated most commonly with the chromophobe type than the clear cell type. So, it actually also has a better prognosis. Okay. So, VHL gene, this pathophysiology, as we basically see, what it is actually doing, whenever there is a gene mutation, a VHL gene protects the HIF formation, but its mutation will ultimately cause the obstruction in the whole pathway, and henceforth the inhibition that was taking place in HIF will be disturbed. So, they will be basically having the HIF formation that it's increasing. What is the HIF doing? It is causing release of certain factors, which is basically causing increase in angiogenesis and ultimately the cancer formation. These factors are important words like VEGF, PDGF, GLUT1 as well as TGF alpha. So, these four names you have to remember: VEGF, PDGF, GLUT1 and it is the TGF alpha. Okay. Now, coming to the natural history, many of the patient comes to us and they don't know whether they were having any kind of a tumor. Recently, yesterday itself, a patient came to me. They did a USG. Why? Because of a epigastric pain. They were having certain gastric issue. A gastroenterologist advised them to get a USG done, and incidentally they found that there is some tumor inside their kidney. So yes, a tumor can be a silent one as well, and in particular renal cell cancer, it might be basically increasing in a size that it becomes palpable, and then the patient might come to us. So a regular health checkup is thereafter advised in elderly age groups, not in the younger ones but in the elderly age groups. So it is an incidental finding in some situations. Some situations they will be basically having symptoms which we will be discussing along later. Most of the patients who are coming to us nowadays, because of the increase in the diagnosis and the imaging studies, are having localized disease. Some of them are having advanced disease, but the noteworthy thing is that almost 30% of patients are having metastatic disease, which is a large number. 30% out of 100% coming to us is having metastatic disease. That is the reason we want that these patients can get diagnosed early, because these are having a very poor prognosis. Okay. Lymph node metastasis is also seen, but the most important and the deadly thing that comes across, which makes the surgery difficult, which makes the prognosis difficult, is the vein invasion. That can be a renal vein invasion, that can be a IVC invasion, and that actually increases the stage of the disease. Okay. What is the most common site where it actually gets metastasized? That is basically the lungs. After that, it actually is the liver, bones as well as the brain, and henceforth the other organs as well. So we should always timely diagnose the situation, otherwise we are going to deal with a very hefty condition. So what is the most common clinical presentation? As I just said, the most of them are coming as without any symptoms. It is actually an occult finding. So basically they came, they found that they actually are having a tumor on the imaging. Apart from that, no symptoms. But if they are having symptoms, what can it be? So it is most commonly hematuria. We find a classical triad, which is a favorite question of the examiners as well. And this triad is actually the flank pain, hematuria, as well as a lump that is basically seen. So a basic thing that comes across is that this particular thing is indicative of an advanced tumor. Normally a kidney is not palpable, but if it is becoming palpable means it has enlarged enough to ultimately cross all the boundaries, advanced, and thereafter it is actually becoming palpable. Also, if it is showing hematuria means it has actually ruptured the whole pelvic elastic system, and thereafter the blood is coming inside. So presence of hematuria, presence of a pain, and presence of ultimately a palpable nature is actually a situation of a classical triad. Seen in a very less situation, it is almost indicative of an advanced disease. What is the most common symptom? That is hematuria. Second most common symptom, flank pain. Third is the palpable abdominal mass. Apart from that, the most important thing that we need to know is presence of paraneoplastic syndrome. So there are certain hormones which are basically excreted by the tumor itself. So this particular things leads to certain syndrome, which is the paraneoplastic syndrome. So what are the different hormones which are excreted? It is including the parathyroid-like hormones. What will it do? It will cause excretion of calcium. So ultimately these patients are having hypercalcemia. So the patient comes to us having no symptoms, just presence of hypercalcemia, and a USG finding showing us this. So we can relate that there is a renal tumor and there is an associated paraneoplastic syndrome, which itself is a prognostic finding in this manner. Second is the release of erythropoietin. This erythropoietin leads to the formation of polycythemia. Third is the release of renin. Ultimately, patients of renal tumors are having more chances of hypertension. So basically, gonadotropins, as well as it is the release of adrenocorticotrophic hormones. So they are having more chances of Cushing syndrome. They are basically also having the release of prolactins. So now we don't need to remember the exact paraneoplastic syndrome. If we remember these particular things, we can easily remember the everything as well. So this is the paraneoplastic syndromes as we see. Most common thing is fever and increased ESR. This is the first thing that actually takes place. Fever along with increased ESR. Thereafter is basically the presence of anemia. Patients are always having cachexia, they are basically having weight loss, they are having fatigue. So they are always in a tired situation. Apart from that, presence of Cushing syndrome, presence of hypercalcemia, presence of polycythemia, and also one very important thing, presence of liver dysfunction. So these patients will have liver enzymes which get disturbed even without any metastasis into the liver. That is called as non-metastatic liver dysfunction, also known as Stauffer syndrome. So this Stauffer syndrome is a very important MCQ again. So again, paraneoplastic syndrome, as I said, the increased ESR along with leukocyte reaction or the fever is the most common thing. Apart from that, presence of polycythemia because of erythropoietin that is released, presence of Stauffer syndrome or non-metastatic hepatic dysfunction because of the gonadotropin release, the Cushing syndrome, and thereafter the prolactins that were released, ultimately causing the feminization, and thereafter it is the hypercalcemia, which is because of the parathyroid-like hormones. So paraneoplastic syndrome itself is a short note, and we need to remember each and every one of them very by heart. That is why I have given some time here. The hormones, if you remember, you can easily take out the paraneoplastic syndrome as well. Now, what are the blood investigations? Again, if you know paraneoplastic syndrome, you will understand what are the blood investigations to be given. So, a CBC, we expect polycythemia, we expect anemia. Creatinine, it gets disturbed obviously because of the obstruction in the kidneys. Presence of leukocyte reaction, so a total count can get increased. So, ultimately fevers can come across. Presence of liver dysfunction, so a LFT findings should be done. We can find the difference within the enzymes, and that is getting elevated. Also presence of calcium, that is hypercalcemia. One very important thing, many times what we do is a tumor marker. There is no specific tumor marker for the kidney tumors, but still one that is taken across is the LDH. So LDH is one such tumor marker. So you don't need to remember all these things, because if you remember paraneoplastic syndrome and if you remember the clinical symptoms, you can easily make out what investigation you should do. So a CBC, KFT, along with the presence of LDH, calcium, LFT. All these things are important investigations. I said ESR, so that comes in the CBC itself. Now, anytime we are dealing with any of the urological pathology, a urine analysis becomes must. And if we are suspecting a tumor, it becomes even more important. So what are we expecting? A routine examination showing presence of blood or RBCs. Also, we do sometimes cytology. So the malignant tumor cells, they are getting basically dislodged, entering into the urinary tract, and ultimately this particular things are getting caught into the microscopic examination known as urine cytology positive. Getting a urine cytology positive is a very rare situation, and if it is coming out, that means it's indicative of an advanced disease. So it is a non-specific finding, but not a very sensitive finding, but if it is present, it should always be taken care of. And apart from that, as I just said, urinary markers, it is not routinely used in RCC, but when you will basically know about the urinary bladder, it is something which is having lots and lots of urinary markers. So urinary bladder cancers will be basically having urinary markers itself coming outside as a short note. Again, diagnostic workup. So we all know that if we are basically examining a patient, we are taking the history of the patient. Symptoms we all know. We know that basically this patient may have presence of a palpable lump. So ultimately that is one very important thing. The palatability gets disturbed because this lump gets fixed to the basic fascia. It ultimately gets fixed to the nearby structures. So henceforth the palatability gets disturbed. The movement with respiration can also get disturbed, right? Apart from that, the investigations, we have already discussed in details what are the things. This is something taken from the book, but by basically the most common thing, whenever a patient comes to you as well or anybody, what you will basically suggest, you get a USG done. So USG is the first investigation always, and that USG helps us to basically differentiate between a cyst and a different kind of a SOL. Now we are saying it SOL because we cannot define the nature of the tumor with the USG itself. So we, whenever find any finding of this kind, we have to basically confirm it with a better investigation, that is a CT scan or an MRI. Now what is the CT scan showing us? Extra information that the CT scan shows us is the confirmation of diagnosis. And how do you confirm it? By seeing the enhancement. What is enhancement? So basically we give dye inside the body, and this particular dye is something which is basically going to take up by the tumor more, and ultimately they will enhance. So they will be basically more bright than the rest of the kidney. So that is actually going to be indicative that this is a tumor. And if the enhancement is more than 15 Hounsfield's unit, it is taken as a renal tumor. Apart from that, we can also do a local staging, whether this particular tumor has spread to the nearby areas, lymph nodes are involved or not, any other organs are involved or not. And also the CT scan helps us to almost get the localized staging that is basically there. Suppose we are suspecting a renal vein invasion. What is the best investigation mode? It is always going to be a MRI. MRI actually has a much better soft tissue resolution. So any forms of a renal vein that is actually getting invaded by the tumor, we are going to see better by the help of MRI with respect to any other things. So basically what is happening, if this is the kidney, it is basically having the tumor that is growing from this particular area. This is the Gerota's fascia, this is the paranephric fat, this is the perinephric fat, and this is basically the capsule of the kidney, this is the cortex, this one is the medulla, and this is the pelvis. So any tumor which starts to grow, grows here and grows here as well. So if it is growing here, it will break accordingly, it will bring about hematuria. It's growing here as well, it is pushing the capsule, causing the pain. It is growing even beyond that, it is causing the palpable lump. Okay, this is the way it actually goes. Metastatic workup. So always remember, whenever there is a tumor that we are dealing with, first is the diagnosis. Second is basically the confirmation of the diagnosis by certain investigations. Third is the staging of the disease, which is to be done localized, and thereafter it is the systemic staging. So systemic staging is to basically define if there is any forms of a metastasis which has taken place in the body, because accordingly the whole management changes. So how are we going to do this? We all know about something called as a PET scan. Although it has a lesser role in this, we can just simply go for a CT whole abdomen along with a CT chest, or a simple chest X-ray as well. Apart from that, we can also do a PET scan. Okay. Bone scan is something which is done when the patients are saying that they are having pain all across the joints, and we are also finding the patient is having a tumor inside on the imaging studies. So we can suspect that there is always a chance of bony metastasis, because as I said, lungs is the most common, hemoptysis, coughing, this is signs of metastasis. Ultimately bony pain, it is a signs of osseous metastasis. Okay? So whenever you are having any of these conditions, you have to confirm it. So basically chest you have to look at because lungs are the most common. Bone scans you have to look at according to the symptom of the patients. PET scan, as I said, is not conventionally done for particularly the renal tumors, but for the prostate tumors it is to be done. What about the renal biopsies? Now we know that normally what we do, any tumor, chalo, let's do a biopsy, confirm the diagnosis and then treat. There are certain tumors which don't require biopsy. For example, if a patient is having a breast tumor, we 100% do a biopsy. Prostate tumor, we 100% do a biopsy. But for renal tumors, we don't require a biopsy. For bladder tumors, we don't require a biopsy. We can do initially with the investigations and straight away go for surgery. But there are certain points where biopsy are required. What are these points? This is the question that is actually asked in the examination. So these points are that we are not certain about the diagnosis even on all the investigations that we have done. Particularly when there is basically a oncocytoma as well as a renal cell tumor. As I said, they are having imaging studies as well as pathological things which are almost all similar. Second important thing comes across, a patient is already having advanced disease, he is an inoperable patient and we have to give some treatment to this patient. So we have to confirm diagnosis, then only we can start with radiotherapy and chemotherapy. So any chemo or radiotherapy, if we have to start, we cannot operate, we have to do a biopsy, confirm diagnosis and then go forward. Similar thing happens in metastasis as well, because in metastasis we cannot directly go for surgery. We have to downstage the disease by giving chemotherapy and thereafter we can move forward. So again, chemotherapy people or oncologists, they say, do a biopsy, confirm me the diagnosis, then I will accordingly give the treatment. Why is that particular thing important? As I said, there are multiple histologies of a renal tumor. Papillary alag, clear cell, sarcomatoid, any variety. So accordingly, they can also plan with the different chemotherapies, right? So how we basically do this particular renal biopsy, it is done by USG guided normally. It can be also done CT guided. So basically it's image guided biopsy with a true cut. But if a patient is already having presence of bleeding diastasis or the patient is having increased on antiplatelets, we need to avoid it or we have to stop it before we are doing it. So these are certain images of the renal tumors. Here we can see there is particular area which is basically looking different from the rest of the other areas. So this is a tumor and this area is actually the adrenal gland, this is the kidneys. So basically tumor on one side, adrenal on the other side. This is basically indicative that there is a adrenal metastasis that has taken place. Again, a similar thing, this particular tumor has almost involved the entire kidney, so we cannot find any normal architecture of the kidney in the entire length. But then we also find that, see, this is basically the IVC, this area. This is the renal vein, that is also the renal vein. So there is some abnormality here as well. So this is the renal vein involvement. So I am not going into details because obviously this is not at your level. So these are all different diagrams that are there. As I said, that there are simple stagings which are going to be there. Any tumor which is basically confined within the capsule is stage 1. It is going outside the capsule, entering into the perinephric phase. Ultimately, it comes out to be stage 2, but it was within the Gerota's fascia. When it is basically going beyond the Gerota's fascia or it is entering into any major veins like the renal vein or the IVC, it is coming as stage 3. And if it is basically going outside and involving different organ, it becomes stage 4. But this is the TNM classification. Just need to remember this TNM classification. It is easy, that it is basically having the stage 1. Again, tumor again confined to the kidneys, less than 7 centimeter size. If the tumor is basically having involvement of, the second stage is basically again confined to kidneys, but the size increases. So here it was less than 7 centimeters, here the size basically increases. Third stage is any of the area which comes across, which is going to be having perinephric tissues, adrenal or major veins. Again, it is not beyond the Gerota's fascia. So that is the reason we are having a lot of importance for Gerota's fascia, because once it is breached, it is the highest stage of the kidney tumor. So Gerota's fascia and ultimately beyond, this tumor is already advanced. This is just the same thing of the whole situations. As we can see here, a tumor that is basically coming across here, it can enter into the renal vein, it can enter into the IVC. So if the IVC or the renal vein gets involved, or it is basically having the involvement that is going to be in within the perinephric area, this is the stage 3. Anything which is beyond that is the stage 4. Same things going on. Now anything that is having basically diagnosed, we should also know how is the prognosis, because the first question asked by the patient is, okay sir, we have been diagnosed with this, how about my life, how am I going to live, how long it is basically going to give us the survival. So it is defined by certain prognostic factors. We did basically a biopsy, or we basically took out the tumor by a surgery, and then we actually see the stage of the disease. So it is actually something which is going to define the whole thing, and rather it is the most important of all. Obviously, this is something which a layman can also say, oh, bada tumor hai means it is going to be dangerous. So any tumor which is large is going to be dangerous. And as I said multiple times, it is the chromophobe which is the best variety, but it is the sarcomatoid which is the least variety. Apart from that, any of the paraneoplastic syndrome areas, if we find in the laboratory finding, it has a prognosis that is not going to be good. So that is the reason I said paraneoplastic syndrome is very important. Patients are having metastasis. Again, the metastasis is also going to be defined as that it is only lung metastasis, only solitary metastasis, or it is multiple metastasis at multiple levels. Bony metastasis with lung metastasis that is coming across, or only bone metastasis but at multiple areas. So it is the burden, site, and ultimately the multiplicity. All this is going to define the prognosis. So now comes to the management. So basically, always remember that renal tumors are surgically managed mostly. Any stage which is 1, 2 or 3, that means it is not beyond the Gerota's fascia, is the one that can be managed easily by the help of surgery. And what kind of surgery that we do here? Suppose a patient is having a tumor that is basically located in this area, or a tumor that is located in this area. Are we basically going to cut the whole kidney, or we are going to take out only the tumor? It is in the initial days we used to take out the entire kidney. But now, because of the advancement, because of robotic surgery, because of the different latest technologies, we are able to take out only the tumor portions, save the rest of the kidney, and that is something called as nephron sparing surgery. Okay? So basically, as I just said, localized disease, stage 1, 2, 3, surgery is the best choice. When are we planning for a radiotherapy although, and not the surgery? It is for those who are basically cannot be operated. It is an inoperable case. Patient is not fit for anesthesia, etc. So what kind of surgery that we are going to do? Mostly, if a tumor is large enough and it actually has involved the almost this level of the kidney, that it is, if we are going to cut it, ultimately the rest kidney which is left behind is not going to survive itself. So then we have to take out the entire kidney. That is something called as a radical nephrectomy. And when we are doing a radical nephrectomy, means we are also taking out the lymph nodes. We are also taking out the whole of the Gerota's fascia, a fat that is present outside, that is present inside. If we are leaving behind anything, that means we are leaving behind some tissues. Is there a role of adjuvant chemotherapy? Do remember, this is a question asked. Chemotherapy or radiotherapy is not having much role in kidney tumors. Take home message is, surgery is the treatment of choice in most of the situations. Only in inoperable cases, metastatic conditions, or patients who are having no treatment options available, chemotherapy and radiotherapy is the choice. Where are we going to give chemotherapy? Although, if we have done the surgery, biopsy came across, we found that according to us the surgery was good, but still we have left behind some tissues. There were certain lymph nodes which were not resected out. The tissue was taken out completely, but the biopsy has come out to be sarcomatoid variant, a very bad prognosis. So in any of that particular situations, we have to give a adjuvant chemotherapy so that that particular area gets subsided and the recurrence does not take place. What is cytoreductive surgery? Cytoreductive nephrectomy is not like we are removing just a small portion of the kidney. No, it is like exactly the radical nephrectomy, but it is basically done in a metastatic setting. So suppose a patient comes to us, they are having a single lesion in the lung and they are having a large tumor in the kidney. Okay, and these are the patients who are actually having hematuria continuous. They are saying, please stop my blood coming in the urine. It is basically causing me to get entirely weak. It is causing me to get disturbed. So in that situation, the patient has to be given the benefit, not only symptomatic but also therapeutic. Symptomatic by decreasing the symptoms, taking out the kidney, hematuria gets stopped. therapeutic means we are decreasing the tumor burden. So ultimately the tumor burden is getting decreased. There are reports which have suggested that if we do a cytoreductive nephrectomy, less than 1% instance, although the lung lesions can get resolved simultaneously without doing anything. So radical nephrectomy is an area where we are not only removing the kidney, we are also taking out the aorta fascia, trying to take out the adrenal gland. Adrenal gland is something which is basically, if this is the kidney, adrenal gland is an area which is like this. So we take out the entire whole thing when we are taking out. So basically the adrenal is also taken into the picture. But nowadays, if we find that it is not getting grossly involved, if it is a lower pole tumor, if it is a small tumor, we try to spare the adrenals. Okay. Also, a lymph node has to be done, lymph node dissection from the crust of diaphragm to the aortic bifurcation. So nephron sparing surgery, as I already told, patient comes to us. This is basically the situation. The patient is having a tumor here. The patient has a tumor here, as well. So we normally will say, no, we will do an entire nephrectomy for this. But suppose this patient, similar patient, has a similar situation in the other kidney as well. Are we going to take out both the kidneys? No. In that situation, the role of nephron sparing surgery comes across. So it is although something which is technically demanding, but we have to do it. Okay. Second important thing is, suppose already one kidney was taken out for some reason. The patient is having only one kidney, that develops tumor. Again, what you are going to do? Try to do a nephron sparing, try to preserve whatever kidney is left behind. Third thing is, this patient is having a severe pyelonephritis, kidney is present, but it is already disturbed. So it will somehow, someday get washed off. And now this kidney, which was the good one, develops tumor. So again, a similar situation. Patients who are having tumors, which I just said, is a single tumor present here. Again, a nephron sparing surgery. So 4 basic indications you need to remember. Bilaterality, it is presence of single kidney having tumor. It is basically having hereditary syndromes. It is having RCC in an area where the contralateral kidney is already disturbed enough that the future is glimpsed for that particular kidney, and if the tumor is small. Suppose this is the same situation, we are having 3 things, and ultimately it is so technically demanding that the surgeon says, I cannot do this. I don't know how to do this because I can leave behind the tumor. It is so small in multiple areas. Might be I will not be able to locate the tumor once I open the kidney. That actually happens. In that situation, the role of radiofrequency ablation and cryoablation comes across. So you need to remember both the things. Nephron sparing surgery is 3 things: surgery itself, or it's the radiofrequency ablation and cryoablation. Cryo means, anybody knows what is cryo? Cryo means it's basically cold. Okay, so anything which is freezingly cold, it is something which is cryo. So we are freezing the tumor at temperatures where it actually all the cells die. Or radiofrequency ablation, that means we are heating the tumor and ultimately boiling it off. So either we heat it to the level extent, or we basically freeze that thing. So this is called as radiofrequency ablation or cryoablation. So ultimately we will be able to save the kidney. And since this is done image guided, so we are able to localize it well. Why then though we should do this in every cases? Why we don't do it? Because it has higher chance of recurrence. So that is the reason we prefer this first. If this is actually not possible, then we do this. Radiotherapy, as I said, has a very limited role. I'll just skip that particular thing. Coming to the metastatic condition. So metastatic condition, I said, one was the surgery, which was cytoreductive surgery, therapeutic advantage, as well as it was having the symptomatic advantage. The other comes out to be radiotherapy. As I said, one setting where radiotherapy and chemotherapy has a role is when surgery is not possible and when the patient is already having a metastatic setting, when we need to downstage the tumor, when basically the patient is not able to operate because it is having certain medical issues. So ultimately the radiotherapy and chemotherapy comes into the effect. Most important that we need to understand, which has now come as the most advanced thing, is the role of immunotherapy and target therapy. These are 2 things that you need to remember in metastatic disease. Surgery, radiotherapy, chemotherapy, everybody will be able to say. Teachers will be interested to know whether you know these 2 words, targeted therapy or immunotherapy. These are the 2 most new advancements that has come across in the metastatic settings. So this we have already discussed. Patient was having severe hemorrhage, severe pain, any paraneoplastic syndrome. That means the patient was having fever, ultimately weakness, anemia. So he wants to get rid of all these symptoms. We do a nephrectomy. Also, since we are doing this nephrectomy, we are decreasing the tumor burden as well. So these are the two main advantages where we are basically having a palliative or a cytoreductive nephrectomy done even in the metastatic settings. As I just said that if we are basically doing so, sometimes there is a spontaneous regression of metastasis, although rare, but it has been reported. And if there is a solitary metastasis, then we can deal it separately, and that is either by radiotherapy or ultimately either by surgery as well. So solitary metastasis with renal tumors nowadays is a completely treatable condition. So radiotherapy, as I just said, it is something coming out within the metastatic conditions. And please do remember, radiotherapy, it also has a role, particularly when there is a brain metastasis, when there is a bony metastasis. So we have to basically give radiation there. Ultimately, that has a magical role. Chemotherapy, as I just said, it is a chemo-resistant tumor, so not much of the role. But the most important thing that comes across and that you need to remember is presence of targeted molecular therapy, which includes VEGF inhibitors. I just said one very important slide, that was the VHL slide, where there was a HIF1 that was increased, and ultimately what they were doing, increasing certain factors, VEGF factors, all these things. So now targeting that particular areas, these molecules have been developed. So it is the mTOR, VEGF and MET. So these are basically those particular target sites where if they are getting inhibited, the tumor itself will not form. So that is actually going to be having sunitinib, pazopanib, everolimus, temsirolimus, and this is basically MET inhibitors. You need to remember the names, difficult for your stage. Again, the word immunotherapy, you just remember that the immunotherapy initially was started with interleukin 2 and thereafter it was interferon alpha. These two were the initial immunotherapies which came across, but they were not so successful. They had lots and lots of side effects, and that's why more advancements came across, and ultimately we developed certain biological agents. Now these biological agents nowadays are used in every field, whether it is dermatology, whether it is any other areas. These biologics are something which is giving very promising role. Bevacizumab, sorafenib, sunitinib, temsirolimus, all these are monoclonal antibodies. Okay. So we have seen that basically a multimodal approach is what should be done for a kidney tumor. So it's not only surgery which is good enough, it should also be basically having a role of chemotherapy, radiotherapy depending upon the stage of the disease. So first we diagnosed, then we staged, then we did a systemic staging, and then accordingly we decided the treatment. Initially it was surgery. If it is a localized disease, stage 1, 2 and 3. If it is an advanced disease, metastatic setting, surgery becomes again a role for treating the therapeutic as well as symptomatic areas. Chemotherapy, radiotherapy for those who are basically having advanced level, shrink the tumor, or it is actually going to be in areas like osseous as well as the brain metastasis. Sometimes the patient cannot go out surgery in that situation settings as well. And the newer molecules which has come across is the biological agents or the monoclonal antibodies or the immunotherapy. And the other thing comes out to be the targeted areas, the areas which are basically going to be getting activated, causing the enhancement of renal tumors, mTOR, VEGF and MET. So immunotherapy, I have just told you, remember these two names. Apart from these names, bevacizumab, sorafenib and temsirolimus. So this is basically the thing. It is a rare tumor, but because it is having an increasing incidence, and that is because of the change in the lifestyles. Obesity, hypertension as well as smoking, this is becoming something which is common nowadays. Metabolic syndrome is something which is becoming common nowadays. So ultimately the incidence is increasing. So henceforth we have to take care of it. Surgery, as I said, is the only method by which we are treating it. It is a radioresistant tumor, but palliative measures can be basically helpful. And remember these names because it is something which is going to be asked in exams. Okay. So it's always a multimodal approach. Recent advances are immunotherapy and targeted therapy and surveillance. Surveillance means what? Suppose we have treated the tumor and now we say that go home. We don't say that. We say that you have to stay in follow-up because there is always a chance of recurrence of this tumor. And so that once the recurrence takes place, and if it is again timely diagnosed, we can again handle them. But suppose a patient was treated well, we did a very good surgery, The surgery biopsy came out to be good, excellent. Patient again came 5 years back and said, again I have a tumor. Now what to do, sir? So it was because he lost in follow-up. So a follow-up either with the yearly scans, or it is basically a height stage disease with the 6-monthly scans, are very important to diagnose any forms of a recurrence that is taking place, because the highest chance of recurrence takes place in the first 2 or 3 years of the surgery. So surveillance itself has a very important role. This is rather the most important thing. If the patient don't stay or stick up to this, they will have no value of treatment.